Hi, and welcome to today's webcast, Skilled Nursing Facility Patient-Driven Payment Model, a focus on clinical care delivery. I'm McKnight's editor, Jim Berkland, and I'll be moderating today's event. We're going to get a look at PDPM today in a way that is going to get down to some of its roots and explain it to you as you probably never heard it before. The elements and strategies will be right there before us. And taking us down this very educational path will be Todd King, Senior Director of Clinical Services for Long-Term Care, and Nancy Losbin, Senior Director of Quality Services, both with Omnicare, a CVS health company. They'll jump in right away, but first I'd like to tell you about some important things for today's presentation. Please get ready for some excellent note-taking opportunities. The slides will not be available for download today, but this presentation will be available for reviewing or viewing for first-timers shortly after it ends. The session will be archived and available on demand by simply going to the registration page to enter this studio. The URL is mcknights.com/January29webinar. You'll see that again at the end. If you are having audio problems with this broadcast, please first check the volume control on your machine. This is the most common cause of hearing problems. You also have a help button you can use if your own troubleshooting doesn't work. Also, we will have time for a Q&A session near the end of Todd and Nancy's presentation. If you have any questions, please feel free to tap them out and submit them directly to us, starting now, in fact. Those we don't get to in real time will be answered afterward. Now, regarding CEs, this educational offering has been reviewed by the National Continuing Education Review Service of the National Association of Long-Term Care Administrator Boards, and NAB has approved this for 1 clock hour. However, you need to stay tuned to this event for its entirety during its original broadcast in order to receive a certificate. Note that since April 1st of last year, all licensed long-term care administrators seeking CEs must provide their NAB CE Registry ID number in their webinar registration form. We cannot verify or report attendance to NAB CE Registry without this information. If you need more information regarding compliance with these new CE rules, please go to nabweb.org/CE Registry. And we'd also like to note this program is made possible by support from Omnicare. Please visit your friends there at www.omnicare.com. Now, a little bit more about our presenters. Todd King serves as Director of Clinical Services for Omnicare. He manages consultant pharmacists and clinical managers, implementing clinical programs and managing facility formulary, while providing education for staff and customers across a wide stretch of America. Nancy Losbin is a consultant pharmacist and is the Senior Director of Quality Services for Omnicare. She holds a certificate in gerontology and has spoken on many long-term care-related topics. Like Todd, she is also a fellow of the American Society of Consultant Pharmacists and has held many prestigious posts with industry groups. Well, Todd, there's a lot to adapt to with all of this PDPM preparation, no question, but what do you think the most important thing providers really need to get up to speed on still regarding clinical aspects of PDPM?
Well, thanks, Jim. I appreciate the question. And, you know, when Nancy and I started preparing and looking at PDPM, we really saw some opportunities around what CMS has done around the reimbursement with clinically complex residents and clinically complex conditions. So what we hope to do today is kind of talk a little bit about that and give some ideas and some opportunities on how facilities can really get the most out of their outcomes with this new process.
All righty. Well, that sounds like a great jumping off point. If you're ready, why don't you take it away?
Yeah, once again, thanks, Jim. And Nancy and I'd like to, first of all, thank everybody for jumping on the call and the webinar today. We're really excited about the opportunity because with this new case mix reimbursement process, PDPM, as we all know it by now, there seems to be a lot of opportunity out there. And many of you are probably wondering, well, why are two pharmacists here today talking to us about this new case mix reimbursement model? And you know, as I mentioned previously when Jim asked the question, we do really think there are some opportunities for providers to dig into the clinical aspects of the reimbursement models and also look at the changing environment and opportunities to provide the highest quality outcomes at the most appropriate cost for your residents. So what we're going to do today is kind of go through some of the background information about PDPM, talk a little bit about some of the nursing aspects, non-therapy ancillaries, which is a hot term that you guys are probably familiar with. We'll dig into those a little bit and talk specifically about some of the conditions that we're going to be dealing with more frequently in long-term care facilities. And at the end, we're going to tie it up with a couple case presentations of some actual potential residents and some of the opportunities that we see from using this model on some of these new types of reimbursement structures that we'll see. So Nancy's going to go through predominantly the background information and talk a lot about the ways that some of the things are changing and some of the clinically complex opportunities that there will be out there. And we're really looking forward to the opportunity and would appreciate your questions at the end, as Jim mentioned. So Nancy, I'm going to turn it over to you, and we'll be discussing a lot of things going forward, and I'm really looking forward to the presentation and going through the questions.
Well, thanks, Todd. I appreciate it. As you well know by now, the goal of PDPM is to provide patient-centered care and to treat the whole patient instead of reimbursing nursing facilities primarily for rehabilitation services. We'll be looking on October the 1st, 2019, the beginning of CMS's fiscal year. RUGs will be discontinued abruptly, and the patient-driven payment model will replace it. PDMP, as it's called, will focus us on clinical conditions, patient diagnoses, comorbidities, and history of the most recent hospital stay for reimbursement rates. Rehab services will take a lesser role in reimbursement, and PDPM will affect Part A, keep in mind, but not Medicare Advantage patients. I think that many of our administrators would consider the ratio of Part A to Medicare Managed Care and determine if the Part C type of patient or Medicare Managed Care patient would be appropriate for your facility and the services that you provide, or you're ready to jump right in and continue Medicare Part A patient services under the new reimbursement system. So what we'll see is a shift from non-therapy ancillary services and nursing services, and less emphasis on services that were delivered through rehab or extensive services that you've seen. What we'll see is a combination of extensive services with non-therapy ancillary services and with nursing services to deliver a case mix that finally reimburses the facility for what the services they actually provide. What we'll see under this new system is that your per diem rate should be budget neutral, where rehab therapy will no longer drive payment. Patient characteristics, MDS coding will drive reimbursement. So the emphasis on those assessments and the skills and knowledge of your resident nurse assessment coordinators will weigh heavily on the reimbursement that you receive from CMS for your Part A patients. The overall intent of PDPM is multifaceted. For example, to decrease the cost of rehab therapy by changing its delivery systems and considering group, concurrent, and one-on-one services while separating physical and occupational therapy from one another as it is in RUGs. To increase patient outcomes, basing care plans now on a patient's functional ability and goals. Augment your revenue sources for clinically complex residents and patients who might benefit from therapy but had not been recognized before on using the MDS. And to provide the payment the facility is really due by correctly classifying each resident using the MDS to document patient conditions and their characteristics to put them into a category of payment. So the questions asked is, why are rehab services so important, And why did we focus on them for almost 20 years now? Right now, 90% of Part A stays are billed for rehabilitation services. The RUGs payment rates are certainly not dependent on the clinical conditions except for depression as part of the rehab case mix. And once rehab minutes were categorized, the assessment did not go further to consider any additional needs that our residents were needed to be provided by nursing services or non-therapy ancillary services. So this is a real opportunity for not only the lesser focus on just rehab, but the ability to really use the skills that we have, promote disease state management, open more widely the opportunities for new admissions, develop niche services, and use the new payment model to develop strengths that you've never realized you had before and use them to improve and increase your census. As we compare the RUGs categories to the new PDPM, we will be shifting from our 66 current categories of care to 5 distinct case mix groups that stand alone, but they all now include a case mix. Patients are separated, PT or physical therapy is separated from occupational therapy, and speech and language pathology stands alone, but it does take into consideration now the clinical services required by residents who may have, for example, suffered a stroke or have dysphagia. It will also consider the non-therapy ancillary services and the nursing services, which now have their own case mix groups. PDPM will redistribute payment to the clinically complex that you admit in your facilities. For example, conditions that will pay more under PDPM are things like IV therapy will see an increase in payment, diabetes and medications that are included and embedded into those payment scales for these disease states or conditions. As with anything that's new, there always seems to be, as long as there's dollars and cents involved, some type of catch, doesn't there? Then built into the PDPM are some regressive payments. What we'll see is the physical and occupational payment rates will decline by 2% every week after day 20 of each stay. The non-therapy ancillary services will decline 66% on the 3rd day of a patient's stay. That means that pharmacists may need to help you optimize drug therapy early in a resident's stay, such as by providing admission medication regimen review to help you identify the barriers and adverse effects, medication errors upon transition, to assure that the new admission has a successful stay in your nursing facility while you maximize the payment rate for them. So, of course, that means that the initial MDS will be critical in its accuracy to leverage payment, especially for your new admissions in these 3 categories that have some type of regressive payment. Today, we're going to concentrate on nursing services that require clinical information, ADLs, extensive services, the presence of depression, and restorative nursing to take a look at where your reimbursement is going to come from and how you will begin to identify the residents accurately and build care plans for them. The wonderful thing about nursing services is that it is not regressive in its payment. So once you submit your first MDS and you gather a payment rate for that individual in nursing services, that payment rate will remain the same. For the non-therapy ancillary services, we will be concentrating on the comorbidities and extensive services included in the care for these residents and your payment for those types of services, keeping in mind that even infusion medications are embedded into these payment rates. So, of course, you probably realize by now that the source of all of PDM patient characteristics and diagnoses will come directly from the minimum data set. The facility will submit an admission MDS, and then the next mandatory MDS isn't until the discharge of the Part A stay. So the 14-day, 30-day, 60-day, and 90-day MDSs are eliminated. The discharge MDS will be performed on the last day of the Part A stay. To capture the correct payment, there are new additions and sections to the MDS, including sections I, J, O, and GG, and new diagnoses have been added that include diseases of the colon to assure that you are appropriately reimbursed. However, that reimbursement rate will hinge on the accuracy of the first MDS. So you have until day 8 to submit that initial admission MDS for a Part A stay, and I think that everybody agrees to take their time, assure that you have researched all diagnoses, assessed all conditions, and assured that the MDS is scored appropriately to assure you get those monies that are due to you based on the services you will be providing. So in just an overview, the 5-day MDS can be performed on day 1 through 8. There is an interim payment assessment MDS that has to be submitted no later than 14 days after a change in classification or a change in status. However, if the resident even went out to the hospital, it may not necessarily reset the date to day 1 for the tapering. So that means if you do an interim MDS on the 21st or 22nd day of a rehab stay, you will still suffer the same regressive payment as it was for 2% after the 20th day. Then the PPS discharge assessment will be done on the last day of the Part A stay, keeping in mind that as MDSs are to be compared quarter to quarter, CMS will be comparing your initial MDS to your last discharge MDS to see how the resident progressed and what their functional capabilities are, and then determine the type of payment that you will be receiving for that individual. New to the MDS is information about the qualifying hospital stay. This part of Section J is going to be modified to collect data on the patient's surgical history while they were in the hospital, and there are 29 different surgical history codes, and we have listed just a few of them. Accessing the hospital information, therefore, will be an imperative to enter these items correctly on the new MDS. These 29 codes will help set the primary reason for the nursing facility stay and begin to classify the new admission into a clinical category for payment. The facility nurse assessment coordinators will have to capture all of the appropriate ICD-10 codes used in the new Section I, SNF primary diagnosis, to assure that the diagnosis is reported as the primary reason for admission. Swallowing disorders, aphasia, and special treatments and procedures have always been on the MDS, but now, finally, they will count towards payment in addition to diseases including ulcerative colitis, Crohn's disease, and inflammatory bowel disease. It's been said that as we shift from the cost of rehab, the cost of medications will go higher. as you probably recognize from a number of commercials on television for ulcerative colitis and for Crohn's disease, these are all treated by medications, and they will be the center of the cost for this individual. So it will be very important to capture all of the patient's other conditions as well as their functional abilities to assure that they fall into the best case mix within the category to assure you have the best payment rate. While functional status, or ADLs, has been used for years to score the case mix, Section GG of the MDS, Functional Abilities and Goals, will now assist in CMS's identification of assistance and self-care. Section GG will be asked on the admission MDS and on the discharge MDS to calculate not only the functional status or improvement of the resident during their stay, but will actually also be used in calculating the quality measures for functional abilities. The functional abilities that will be assessed in this section that will count toward payment will be the resident's ability to roll left and right, to sit and go to a lying position, to move from a lying to a sitting position on the side of the bed, chair and bed transfer to a chair, toileting transferring, walking 50 feet with 2 turns, or walking 150 feet. You're already familiar with Section GG, but after October the 1st, these will count in your payment rate. So as you can see from this very simple grid, finally, occupational, physical and speech therapy, as well as nursing services and non-therapy ancillary services will all have a case mix index assigned to them. That means that many questions on the MDS will help improve the reimbursement for these residents based on their characteristics and their needs. However, keep in mind that physical therapy, occupational therapy, and non-therapy ancillary services will be regressive in their payment. So before we had 4 major categories in runs. Today we have a breakdown of 5 major categories with the non-case mix actually based on your rate in October 18 for your cost, so that we can come up with a base per diem rate for your facility. So let's talk briefly about non-therapy ancillary services. This is where your cost is going to shift, and it is one of the most important changes coming our way October the 18th. Non-therapy ancillary services will account for about 43% of your nursing rate as CMS has calculated it from October 2018. But as I said before, it tapers after the 3rd day of stay. It does include the cost of medications which have been embedded into it. Each of the residents has points allocated based on the number of conditions. The average resident has about 6 diagnoses or conditions that we see on any average patient. These all have the ability to now be captured in the MDS and assigned a point value to determine payment for that individual. There are 15 conditions that have greater than 1 point, and that may be where you find your niche service, while there are 30 conditions that have 1 point, but when you add them all up with these concomitant conditions, you will see that there's great value in taking the complex resident into your facility and treating them, because finally we'll be reimbursed for those services. Your attention should be brought to HIV/AIDS, which now has 8 points assigned to it, which is the very highest diagnosis that you will be paid for in the non-therapy ancillary services. But again, how do we manage HIV/AIDS? Well, it's through cocktails of medications and antiviral therapy, nutritional support. It can be vitamins. At times it could be tube feedings and appetite stimulants. So all of these items are captured on the MDS, but again, I cannot overemphasize the accuracy of the resident nurse assessment coordinator in capturing all of these services for which you will be reimbursed. When you just take a look at the reimbursement non-therapy ancillary services, who would have ever thought 20 years ago that long-term care facilities will finally be reimbursed based on the age of the resident? And it appears that the younger the resident is, the more you will get paid. And in terms of Cognition, for example, there's some very granular detail to the science that went behind approving or estimating the cost here. For example, we know that as you assess Cognition, we find residents who are not impaired, slightly cognitively impaired, moderately impaired, and severely impaired. But each one of these has a different case mix to be added to the non-therapy ancillary services and count for payment. So when you see all of these, such as cancer or infections and taking someone into the facility with arthritis or swallowing disorders or after a stroke or sepsis. Before, if we were handling sepsis, we would stop with extensive therapy and that the resident was probably on an infusion medication. Today, these services will be higher reimbursed, and we expect to see an increase of 25% just in IV medications alone. So it will behoove us as we go through this learning process over the next several months to understand your costs today and where they will be in the future. There is a lot of minutia in understanding the technicalities that went in to identify each of these different services and conditions. But quite frankly, what I see here are a lot of niche services, and we must get over the fear of taking residents with HIV or taking residents who have a trach or need ventilator or respiratory services. As a matter of fact, I anticipate that there will be some facilities in dealing with things like respiratory infection, respiratory failure, ventilator services, respiratory services, that we might even see the return of the respiratory therapist back into our buildings. The conditions that are included in non-therapy ancillary services are HIV/AIDS, IV feedings or total parenteral nutrition, IV medications, and respirators. So HIV scores 8 points, while IV feedings or TPN scores 7 points. IV medications or antibiotics used to treat, let's say, osteomyelitis gains 5 points, and ventilator and respiratory services provide 4 points. All the rest have 2 points. But take a look at the ability to do more transfusions in long-term care. Understand taking a person with a lung transplant or a major organ transplant requires you to have the medications immediately available. For example, one missed dose or 1 day of doses missed on a medication that avoids rejection can cause a resident to reject within 24 hours. So we need to bone up on our skills, understand what we need to have available, understand the types of medications such as specialty drugs that are used today to treat and manage multiple sclerosis, asthma, COPD, and chronic lung disease, and take a look at the bone and joint infections. Some of these really need assistance, and the hospitals are driving them out of their setting and right into ours. Certainly with the assistance of your medical director and your pharmacist, as well as your dietitian, There are a lot of opportunities here to take the type of residents that we were a little shy of taking before, but it does mean that we'll need to really lean on one another to deliver holistic clinical services that are multidisciplinary. In addition, there are many conditions that will provide 1 point. However, you'll be getting credit for someone who's got a tube feeding, or someone with an ostomy, or someone who is on MS plus they have an intermittent catheterization, or someone who has end-stage liver disease or chronic pancreatitis. You'll finally get paid for malnutrition. These things become very important, and as you can see, if someone has malnutrition and they're on TPN and they may have an IV medication with that, you're finally looking at someone who might be 4 or 5 points to the advantage when it comes to payment. So non-therapy ancillary utilization was calculated by taking a look at data from Medicare Part C and Medicare Part D prescription claims to risk adjust the conditions that were decided upon to be included in non-therapy ancillary services. These conditions were also mapped to diagnoses from discharged patients to the long-term care facilities that were discovered on the 5-day MDS and included the primary diagnosis for admission. They used Medicare Part C to estimate the utilization of Part A and Part B services, and they used Medicare Part D medication claims to adjust the drug cost prediction for these types of conditions or disease states for which you will now be paid. They used both of these to define the conditions and include them in the non-therapy ancillary services. So I was happy to see things like COPD, for which we know we have residents that go into the hospital several times during the year, in spite of the fact that we've given their vaccines and immunizations and their inhalers. But when you treat someone with COPD, that inhalation therapy or the inhalers, that cost is embedded into these non-therapy ancillary services and the score that is assigned to the resident. Let's take a brief look at nursing services. Nursing services, like everything else, will depend on your MDS data. Some of the data will affect case mix of other categories in payment, such as depression. So while these may seem mundane, and they may be components of the MDS that we've always answered, right now they have far more meaning in that they determine the payment rate for which you will receive from CMS. Most interesting, you can see here that insulin-dependent diabetes is one of those that you will be paid for. But what is your diabetes management program in the nursing facility? Do you want to have a sliding scale for the entire Part A stay? How will you move your resident from having multiple doses of insulin over the course of the day to being managed to maybe 2, 3, or only 4 injections over the course of the day? You will finally be paid for patients who are using radiation or out to dialysis or have, as I said before, cognitive deficits. And even it recognizes in PDPM that behavior management is part of nursing services. It's what we do, providing both drug and non-drug therapy to manage behaviors. And while there are some shifts away in some of the categories of behaviors, you'll see that they finally do recognize that for the chronic care patient, even IV feedings or TPN will be reimbursed under the nursing conditions in PDPM. This is all very exciting and really allows us to take a look at disease stage management and the services we provide, but they're also excelled services, and it really will require a great RNAC, sufficient staff, and qualified staff to deliver the quality of care that we anticipate. The last thing that we would want to do is submit a discharge from Part A with declining ADLs or scores based on some of the case mix index for those patients. So what we need to do is understand that ICD-10 coding will be the primary basis for the MDS non-therapy ancillary services as well as nursing. You've got to recognize that medication will be the primary mode of treatment for these higher cost predicted ICD-10 based diagnoses and conditions that are going to be reimbursed. There is a shift in cost away from rehab, and we expect it to fall into pharmacy services. And that really means that you need someone who not only understands their business, but you need a provider that understands your business to help you manage those costs, let's say, for the non-therapy ancillary services in the first 3 days of care. How good are your pharmacists, for example, in recommending an IV medication that could be converted by the 3rd day of stay to an oral medication so that you can decrease the costs that coincide with the regressive payment for non-therapy ancillary services. One of the things that will be a big change for all of us is how depression and cognition will be assessed. There will be a new measure called the Cognitive Function Scale, and this combines the Brief Interview for Mental Status, or the BIMS, and it combines the Cognitive Performance Scale, or CPS, into a single scale that places a resident into one of 4 categories for cognition. So again, new learning techniques and understanding of how the MDS will be upgraded to accommodate all of the diseases that have been identified by CMS as being served in long-term care routinely, but certainly not reimbursed routinely. When you take a look at all of the 16 classifications for physical therapy and occupational therapy, the 12 classifications for patients with speech or language pathology needs, including things like stroke, dysphagia, and some of the other conditions that go along with speech therapy, including depression, the 6 non-therapy ancillary services classifications and all of its case mixes, and the 25 nursing classifications that you'll be reimbursed for, it is possible that you can have 28,000 different combinations for clinical care from the MDS. Mother MDS will be the document of all documents, but remember, it must be supported by an appropriate care plan and the appropriate documentation to survive an audit of the information and ensure that you have coded precisely to get the reimbursement that you're entitled to. And at this point, I'm going to hand it off to Todd to briefly review the advantages of PDPM and to discuss at least 2 disease states for your consideration so you can understand how the drug costs will start to shift into your day-to-day costs for the Part A stay patients. Todd?
Thanks, Nancy, and great job there on reviewing the background of PDPM and how we're going to be faced with some changes. And I think I'm one of those people, and Nancy's the same way, we see change as opportunity. And I think as we go through these next few slides, you'll see where we think some of the advantages and opportunities are. So as we touched on briefly as we went through the presentation, some of the advantages of PDPM, it does remove therapy minutes as the basis of payment. It establishes a component of non-therapy ancillary services, and we'll touch on that just a little bit as we go through the last 2 cases. It also improves services to the clinically complex by increasing reimbursement for those residents. And the two cases that we do have, one on MS and one on HIV, will just give you some basic background information of some of the multitudes of opportunities that are there for these residents. It reimburses for clinical characteristics rather than physical function, better treatment for vulnerable, example, ventilator residents, infected isolation, end-stage renal disease, and others as they're listed here. As Nancy did a great job at going through those specific conditions and where and how they'll be reimbursed based on the point system. I do think there are situations where, based on some of the, while Nancy was speaking, I was able to look at some of the questions, and I think there is some good information in the Federal Register under the section that looks at the resident and facility characteristics and shows the specific changes from previous reimbursement to the new model. And I think it would be good for everyone to take a look at that, just because it'll give you a little bit better insight on the subtleties between some of the things that Nancy was talking about with characterizing behavioral problems and cognition issues and that type of thing. It pays for each component of care, variable per diem adjustments. We base the resident classification on objective clinical information, which is, as Nancy mentioned several times, is really going to be a key factor when we categorize those residents at admission with all of their information. Also in the Federal Register, you can see, based on some of those characteristics, that yes, urban homes will be reimbursed at a higher rate. There are some other facility characteristics that will change some of the reimbursement rates. So once again, I think it's a good opportunity to go out and look at those areas where some of those changes will occur. So managing PDPM, I think it's important to remember that unlike RUG 4, which incentivizes therapy to capture the payment, PDPM will require the facility to carefully manage how the SNF facility delivers services in order to provide the right level of care for each resident. So that's kind of what we feel is an opportunity to manage this condition moving forward and making sure that we're able to get the reimbursement that's needed and also provide the level of care that's needed. CMS and Medicare does feel that PDPM is designated to be budget neutral. If you go in and look at the Federal Register in the facility and resident characteristics section that I've mentioned a couple times now, you'll see how some of the calculations were done and where the changes in reimbursement are going to be some give and take based on conditions and resident type, et cetera. So that is the plan, is to have this to be budget neutral. We'll see how that goes. I think it does give an opportunity for us to look at different types of residents and making sure that we do look at the clinically complex and treat those residents accordingly. So one of the last couple things that Nancy and I wanted to do before we close out here was just kind of look at a couple specific opportunities and conditions. And I think as the kind of the recurring theme that we've talked about today is a lot around medications and some of the potential issues around medications. I know Nancy mentioned the drop in reimbursement of non-therapy ancillaries after day 3. We really do think that is an opportunity for facilities to partner with their clinical pharmacists and consultant pharmacists to make sure where those transitions and reimbursement occur, that we're making sure we either optimize therapy, look at therapies that are current and standards, look for alternative therapies where cost opportunities might be, look at adding therapies, medications, where there may be opportunities to treat chronic conditions more effectively. So lastly here, we're going to take a look just real quick, and we put this in here just to kind of give you an idea of some of the complex nature that happens with a resident that has MS or multiple sclerosis, and looking at the different types of medications that might be used, looking at some of the other types of areas where this PDPM reimbursement system will allow the facility, if they categorize the resident correctly, to make sure that the reimbursement is there, and then also that the care is there. You know, these residents, they do take corticosteroids, which are medications that have a lot of side effects and need to be managed accordingly. Immunomodulators to prevent disability. These are infusion medications that are high dollar medications, medications to treat spasticity antidepressants, medications used to treat neuropathic pain, bladder dysfunction. Those categories, if you look at the number of medications just right there for a typical MS resident, making sure that you have that pharmacist there to help make sure those drugs are appropriate for that resident and for their condition, to make sure that they're functioning at the level that they should function. Also for these residents, exercise and vitamins, prevention of pressure ulcers and urinary tract infections, self-catheterization, a lot of these other items that are nursing type of services that are things that really need to make sure that when we look at this system, we're able to categorize and move those forward accordingly. And then lastly, we'll look quickly at a resident who has an HIV infection. And Nancy touched on this several times. There may be medications, chemoprophylaxis, antibiotics to treat opportunistic infections. And there traditionally will be antiretroviral therapy or ARTs, and there's a variety of medications in this class that need close management. There are honestly some opportunities now out there with generic medications in this market space where there can be alternative therapies or look at generic utilization to help with cost while maintaining the clinical effectiveness of these medications. Other medications in an HIV resident could be antivirals for herpes zoster infections, antidiarrheals, antipyretics, antimicrobials to treat oral candidiasis and fungal infections. These are opportunistic type infections that come along with the progression of HIV. Analgesics, and then antibiotics to treat sepsis. And making sure with all these categories that when we are in the PDPM reimbursement model, that we are engaging that pharmacist to make sure that that pharmacist is there with us to help make sure that the drug therapy is appropriate as possible. So just to kind of wrap up here, I kind of wanted to, first of all, thank Nancy for her participation. She did a really great job at going through the background of PDPM, and we're looking forward to taking some of your questions. I do think that this is an opportunity for us, and when I say us, facilities and providers and long-term care pharmacists, to partner in a way that probably we hadn't thought about for up until this point. I know that out there are some anecdotal things that have been happening in some small pockets of areas where pharmacists are getting closer to that admission process, but historically, the consultant pharmacist has been more of a retrospective look at the resident's record. I really think this is an opportunity for us to get in front of that resident and that multidisciplinary team right at admission to help with this new reimbursement model. And also, we think that that'll provide a higher, more positive outcome because, you know, we could talk all day about the transitions of care that happen and the issues that happen during transitions of care from acute care to long-term care facility and then from long-term care facility to home, you know, making sure that we do infuse those opportunities to have pharmacists in areas where they can help with those. So I just wanted to say thank you again for taking the time today, and I think I'm going to turn it back over to Jim for some questions, and Nancy and I'll be available here for a few minutes.
Well, thank you very much, Todd. I want to thank both of you for this just really incredible information. As we can see, the questions are pouring in. We'll give you a chance to catch your breath there, Todd, Nancy as well, obviously. But we want to jump right in and let you folks know that, well, first of all, we've had so many questions. The slides are not available for download, but the presentation will be available, as you can see, right where if you go to that URL on the slide right then, and you can view again, and these things will be there for viewing, and if somebody wants to do it for the first time. So let's get to the questions right away. We have quite a few good ones, and if we don't get to them all, we will get you some answers afterwards. So Kim asks, how, where, and when is a comorbid diagnosis such as Alzheimer's or related dementia accounted for or factored into PDPM? Is that easily enough answered?
It's tricky. While the overall reimbursement for dementia appears to be lower, signifying that it truly is Alzheimer's dementia on the MDS will include reimbursement, but you also have to capture all of the conditions that coincide with Alzheimer's disease. So if they need assistance in feeding, or they're incontinent, they need assistance in ambulation, if they are prone to pressure ulcers or excoriation of the skin. Those are the types of things that have to be well documented on the MDS so that you can capture all of those nursing services that feed into the reimbursement. So, for example, taking a look at accurately assessing a resident's cognition scores, and then making sure that if they've improved or declined on that last MDS or Part A stay will be incredibly important. As Todd said, for example, medications used to treat Alzheimer's or to treat cognitive problems may have a lot of side effects or adverse reactions. What we don't want to see is a loss in those functional capabilities, like being able to walk or transferring over the course of their Part A stay. Some of those medications with their side effects, such as lethargy or sleepiness, or could actually impede and lower that functional ability score. And that's where your pharmacist can help you, not only in just the array of drugs that treat Alzheimer's, but also prevent negative conditions associated with the drugs that may be causing a decline in those ADL. I think the greatest opportunity here is finding someone who's got a slight cognitive decline and yet being able to identify, hey, this is someone who can really use some rehab therapy. Let's get them into speech therapy and help them today with their swallowing while it is not a tremendous burden to them, and see if we can improve their skills. This is where it becomes exciting, where these earlier interventions can be grabbed and used successfully, and you'll get reimbursed for them.
Okay, great. Let's try to get to a couple more here, and this next one is so important, but I know we could probably do another webinar on it. Let's get a few responses, perhaps, on your thoughts. As Michael asks, I know we're going to get this. As you are well aware, most facilities struggle with nursing documentation, especially as it relates to nurses accurately identifying diagnoses to justify medication administration. With that said, do you have any suggestions as to what methods and or strategies to implement that would help facilities capture the correct diagnosis to ensure proper reimbursement rates are received? Again, we'll try to get to a couple more questions, but what are your thoughts on that?
This is Nancy. That's a great question, and thank you for it. First of all, you will start with the hospital summary, and your relationship with your referral source and access to the hospital record will be critical in not just establishing and documenting the primary reason for admission, but also all of the problem list and the diagnoses that the resident or the patient came into the hospital with and is being discharged with. Keep in mind, however, that a lot of times hospitals are so focused on the acute care diagnosis that they fail to understand all of the others. Reaching out to the primary physician that a resident had at home and understand what medications they took before they went to the hospital and his or her list of diagnoses for that patient would be very beneficial to capture in the documentation, even if that doctor's not the attending in the nursing home. In addition to that, your medical records vendor should be improving ICD-10 codes, helping you code these diagnoses, associate medications that have diagnosis codes that we understand and know. For example, non-insulin diabetes mellitus would be one of them. However, keeping in mind that nurses can't diagnose, pharmacists can't diagnose. It's not within our licensure. So we have to capture the information from anywhere we can get it, and that means you need an on-the-ball attending physician at admission to do that first thorough physical and examination with a thorough history to get all of the conditions, an array of conditions that each resident who's a senior usually has, including arthritis, osteoarthritis, for example, to make sure that you can maximize the conditions and get credit for them in payment.
All right.
And, Jim, I'll just add to that real quick, if you don't mind. Great answer, Nancy, and that was exactly where I was going to go. The only thing I would just kind of out there with the group that's out there today is how many of you admission people out there see medications come in without a diagnosis? And historically what we would do is we'll say, yeah, this is an admission. We don't have time to get that. We'll get it later. Well, those days are gone in this new system. That's why, as Nancy mentioned, working with your attending physician, your consultant pharmacist to help identify medications that may not have a diagnosis, get it to that primary care provider, find out exactly what it's being used for, and you may have another non-therapy ancillary service that you can code in your system.
Exactly.
Thanks.
All right, very good. I want to get to one more, and then I want to get final thoughts before we do some sign-off. So I'm going to put you on like a 30-second clock here because I think this will go back over something we had. Janet asked, what about reimbursement for expensive cancer meds? We've had a lot of cancer questions. Can you quickly summarize that?
Well, this is Nancy, of course, and yes, this will be an issue in the fact that if it is a non-therapy ancillary service, there will be a decline in your reimbursement by 66%. Assuming that you're doing infusion anti-neoplastics, that will keep the resident in extensive services. So that plus the cancer will increase your score for that individual. But you've got to capture all of that goes with cancer treatment, or if they had surgery for the cancer, if they're still on radiation. You have to capture everything that's going on with that resident in their cancer diagnosis and all the related conditions to assure that you capture enough information to actually pay for that type of medication. Now, some of the oral therapies that we are using today, for example, metastatic breast cancer, they are expensive, and you are going to have to find your niche and learn to balance the clinical care with the type of resident you're accepting. So your due diligence has to be at admission more than it ever has been before you decide to take a resident, and understand the skill set your staff needs, and ask your pharmacist to help you identify those types of drugs, including specialty medications and their costs, and if there are alternative therapies.
Okay. Now the final payoff for the listeners, that's why we always like them to stick around, is after all of these great points and so much information, what is the one thing, if you have to emphasize one thing, that listeners have to take away from this presentation? I'll go with you first, Nancy.
I think the thing that really is, we're just all in the beginning of learning this. And every day as we examine this, we will learn something new. Attend what you can. Do as Todd suggests, download the information. Spend a few minutes each day understanding its development and how it will pay. Understand that the shift of your rehab services, you may be paying 43% less in your rehab bill, and that's where you're going to find the money for your medication bill. So learn to balance. Most of us learn how to read a balance sheet. Go back to 2018 in October. Understand where your costs were so that you can calculate your budget for 2019, 2020.
Very good. And Todd, what would you like to add?
I think, Jim, and to look at places you might not have looked at before. And kind of this is going to shift some of the things that we've done in the past, a lot of things as a matter of fact. And I hope today we kind of gave a little bit of insight on how partnering with your providers and partnering with your consultant pharmacist and your electronic health record, there's going to be a lot of technology come out to help facilities comply with this new process. So look to those areas, because those people are going to be there to help you and want to partner with you, because we're all in this together, and our outcome and our goal is to provide the highest care that we can to our residents. And I think that partnership will help make this happen. So thanks again.
Excellent. Very, very good. And again, we need to thank Todd and Nancy for their outstanding insight on this. And I want to reiterate that this will be viewable again at mcknights.com/January 29 webinar. We also want to thank our session sponsor, Omnicare. Check it out at omnicare.com. And, of course, we always thank our listeners. You've been a big part of the success today, and we look forward to seeing you again at future McKnight's webcasts. Keep up to date on all our offerings by checking the Events tab at mcknights.com. Once again, thank you for tuning in. This is Jim Berkland for McKnight's, wishing you a good week.